Yes, thank you for your question. And first of all, as we know all that PTCL is a difficult to treat disease. And a patient, especially patient in the relapse and the refractory disease, have a worse outcome. And patients who are relapsing have a median survival rate of less than 6 months and above 3 to 4 months of progression-free survival. And patients in the relapse setting who received allogeneic transplant are going better than those who are not. That's why the only curative approach for those patients is allogeneic stem cell transplantation. And for that, we aimed in our work to harmonize the practice of allogeneic transplant is to provide for all physicians a standard how to manage those patients. It's our first aim for that. And 29 experts from Europe and the United States have worked together to draw these guidelines. And for the first line patients, after the first line of chemotherapy, there is no indication for allogeneic stem cell transplantation, as these data are based on the AATT trial. Unfortunately, in the first line, allogeneic transplant will be as investigational treatment. And autologous stem cell transplantation is considered as a standard. However, there is no randomized trial that show advantage on overall survival over chemotherapy alone. However, for the majority of PTCL, in the relapse or refractory setting, allogeneic transplantation is the standard of care. And doctors should be aware for that. And they should look at first for HLA typing and search for off donor. And for chemosensitive patient in this setting, will go directly to allogeneic. And what we should know that doctors shouldn't wait to obtain complete remission. If patients are chemosensitive in CR, PR, or stable disease after one line of salvage treatment, they should go with allogeneic transplant and don't wait until complete remission. However, for patients who are progressive, we can propose to them another second line treatment or clinical trials with the objective to put them on the track for allogeneic transplant. And again, we recommend that no more than 1 or 2 lines of salvage treatment before allo. Don't wait complete remission, and for sure, this is for fit patients. Okay? These recommendations are for patients with the major entities, such TFH, lymphoma, ALCL, or with PTCL NOS. However, for the rare disease, PTCL, like hepatosplenic lymphoma, EATL, or extranodal NKTCL lymphoma, there is a recommendation to go with allo in the first line, in chemosensitive. With some caveat for EATL, there is no firm recommendation to go to allo in first complete remission, and those patients may benefit from autologous stem cell transplantation in complete remission. And if they fail after the first line chemotherapy, the complete remission, in partial remission or stable disease, in this case, those patients should go to allo transplant.